So that good evening to everyone. Welcome to our webinar today, particularly about the yellow phosphorus intoxication. Yashoda Hospital group of hospitals from Hyderabad. Every Tuesday, we try to bring some topics about the current interest for us to do it in day-to-day practice. I think nowadays, not only the particularly the intensive care people talk only about the sepsis is there or the cause, but nowadays we are seeing a lot of people, the young people, which are not having any comorbid conditions. They come to the hospital because of the various reasons. Sometimes the accidental ingestion of the some intoxication, sometimes suicidal, or sometimes homicidal is there, and it's quite difficult people to manage. Sometimes they come early, sometimes they come late, sometimes they are not given the proper history what they are doing, and once they are having a lot of complications and problems, it's become difficult. So that time is very important. Because of the various social reasons, family and the patients, they don't give proper history for us, for the clinicians to understand what the patient is having. As usual, most of the people think that the patient having some systemic issues are there, try to address that, but becomes difficult. I think the syndromic approach is quite important. In the same way, recently we had a case in our hospital, a young female came with intoxication, and then how we subsequently manage the cases. On the board, I welcome Dr. Sunil Karangaru. He is the chairman and the senior intensivist head of the department at critical care medicine at Manipal Hospital, Bangalore. Welcome to you, sir.
Thank you.
And the Dr. Somshekhar sir, who is the senior gastroenterologist at Yashoda Hospital, High Tech City. I think sir is still joining. I just now spoke to him. Welcome to sir on the board. I request Dr. Saiteja to go with the presentation of the case.
Okay, sir. Thank you. Good evening, everyone. Today we are going to discuss about the yellow phosphorus poison, which is one of the most notorious lethal poison without any specific antidote. And I'm going to explain a case which we received in the last 10 days and how we managed the case. So coming to the case, she's a 20-year-old female with alleged history of ratol, that is 3% yellow phosphorus poison, on 4th June and presented to our ER on 8th June with complaints of multiple episodes of vomitings and abdominal pain. She was actually referred from a local hospital after initial resuscitation on the previous, that is on the 7th June. So on 8th June, when we received the patient, she was conscious and oriented. Her BP is 80 by 50 mm of Hg in supine position and heart rate of 113 with sinus tachycardia. The pulses are feeble and low volume, which improved out of fluid resuscitation. Her abdomen was soft and there is mild tenderness. Apart from this, there are no other significant clinical findings. And on visiting the history and previous hospital records, she had ingested the poison, that is 3% phosphorus, which is available as a toothpaste form on at 4 p.m. on 4th June 2025 at her home place. So from 4th to 7th June morning, the patient developed multiple episodes of vomitings with worsening general condition, which ultimately made her reveal the incident to her parents and was taken to a local hospital. So this is the first time she was taken to a medical contact, that is on 7th June 2025. And at that time, patient was conscious, oriented, and with stable hemodynamics. Her blood counts were hemoglobin of 12, TLC on the lower side, that is around 2,600, and platelets also on the lower side is 1.9 lakhs. Urea creatinine within the normal range 99.8, and USG done outside revealed fatty liver changes with gastric wall mild thickening. And LFTs which are available are SGOT, SGPT, that is 51 and 46 with total bilirubin of 1.4 and albumin 3.8. So with these investigations, she was brought to her hospital ER. So at the ER assessment, she is conscious. Venkat sir has raised the hand.
Venkat must raise the hand for the join as panelist. They will take care of her.
Okay, sir. So she was initially hypotensive with the BP of 80-50, but after resuscitation, volume substation, she improved her hemodynamics. So on 8th June, her baseline parameters were hemoglobin of 12.5, TLC same again on the lower side, that is 2,570, and the platelets dropped further from 1.9 lakhs to 1.46 with urea creat of 11.2 and 1. SGOT, SGPT significantly raised to thousands, that is 1,892 to 4,300 with INR of 8, and ABG showed metabolic acidosis with respiratory compensation, high anion gap with the lactates of 7, and she also had hypoglycemia along with hypokalemia. So to counter the ongoing liver damage, we initiated the PLEX therapy as planned immediately with estimated plasma volume measured by Kaplan formula, that is EPV is equal to 0.065 into weight into 1 mass centimeter, and it found out to be around 1.4 liters. So we planned the PLEX with replacement of 1.5 liters with 50% with FFPs and other half with 20% albumin and saline. NAC infusion was started along to the paracetamol protocol. And meanwhile, admission MELD score was around 40. And as the patient was satisfying Kochi criteria, that is the MELD score of more than 36 or INR more than 6 with hepatic encephalopathy for liver transplantation in the Rodenticide poisoning. And she was given an option of liver transplant to the family members. And over the course of 7 days, a total of 5 PLEX sessions were done and 1 CRT session were performed. And these are the trend of investigations from 8th June to 16th June. So as I mentioned earlier, from the presentation itself, she had mild decrease in TLC as well as the platelet count. Possibly could be due to the myelosuppression of the rodenticide, that is 3% yellow phosphorus, which decreased to a minimum value of 57,000 on 14 and slowly started picking up. Whereas coming to the AST ALT, presentations were beyond 4,000, but on repeated PLEX sessions and supportive care with NAC and all, by the end of the 16th June, the AST ALT have come down to a level of 71 and 126. The initial INR was 8, and at this time we have transfused the patient FFPs and we have taken the dialysis sheet for the PLEX treatment. And over the course, it has decreased and reached to a baseline of 2 to 2.3. And total bilirubin at the presentation was around 1.9. On around third or fourth day of our ICU admission, it reached to its peak of 11 and 11.4. Now it has settled to a range of 9.5 to 10. Lactates on the first 2 days are beyond normal, that is around 7, 11, and 5. But after resuscitation and slow regeneration of the liver, it has come to a normal. Only elephant abnormality we got was around hypokalemia. That would be because of the possibility of repeated vomitings patient presented. So on day 6 of admission, as patient overall condition was improving, the decreasing INR, AST, ALT, and lactates, post 5 sessions of PLEX, patient was shifted to our HDU for 2 days and later on shifted to general ward with stable hemodynamics. So this is one of the prominent trial which was published by CMC Vellore. They have recruited the patients aged less than 18 years from for around a 4 to 5 years period. And they found a significant benefit in mortality for patients treated with PLEX therapy without any PLEX therapy. So what they Tamil Nadu is one of the state which is affected by the rodenticide poisoning predominantly. So from 2021 to 2024, the government itself has taken is an important role, pivotal role in controlling the mortalities of the rodenticide poisoning, that is especially yellow phosphorus. What they used was a hub and spokes strategy. For each and every district, they maintain a major center which performs a PLEX therapy. And whenever there is any admission on the nearby peripheral centers, immediately the main center, district headquarters, will be informed, and the patient will immediately shifted after basic registration to the centers which performs the PLEX therapy. In this way, they found that there was a significant decline in the mortalities reported with the yellow phosphorus poisoning. As we can see, the serial milestones achieved by the Tamil Nadu government, that is organization of workshops for the doctors, and in 2022 they even formed PLEX teams in all MCHs, medical centers, medical health centers, as well as they have even passed regulations for the sale or to control the sale of yellow phosphorus and its management protocols. So as we all know, yellow phosphorus doesn't have any antidote. Basically, the phosphorus is available in the two forms, that is the metallic and non-metallic form. Yellow phosphorus is the non-metallic form, which is commonly available in the paste form or the foam form. So when compared to the non-metallic forms, that is yellow phosphorus, metallic forms like aluminum phosphate, zinc phosphate, generally liberate phosphine gas whenever they come in contact with acid or water. That's why majority of situations, generally, it is not advised to gastric lavage, especially in aluminum phosphate, zinc phosphate, leading to the release of phosphine gas. Whereas non-metallic forms like the yellow phosphorus, careful gastric lavage with either potassium permanganate or some lipid emulsions like coconut oil can be performed. Whereas coming to the plasma exchange, as we all know, the plasma exchange has brought a significant mortality benefit, especially the high volume plasma exchange, that is 3 to 3.5 times the plasma volumes, has found a significant benefit in paracetamol poisoning. Whereas a CMC trial, which they have included around 75 patients, they found that even the low volume plasma exchange, that is around one or less than one plasma volumes of exchange, has found to be beneficial, especially in pediatric patients with significant mortality benefit. And for the liver transplant, as we all know, there are multiple criteria, multiple scoring systems to select the patient who are eligible for the liver transplant. What commonly used was, especially in the South India, is the Kochi criteria as well as the MELD score. And
Okay, Sai, we'll
yes,
discuss about rest of things.
yes,
Thank you, Sai, for presenting that case. As
okay.
we told as I told in the introduction, a lot of the young patients which are not having much of comorbid conditions, because usually we think when the patient coming to the ICU with the multiple comorbidities for the patient, hypertensive, diabetic, CVA, with getting multiple complications and problems. But now I think a lot of the epidemic of the cases, at least previously we used to see rarely the cases of intoxication. Previously it was only one or two OP poisoning or snake bite is there. But nowadays, as the science advancing and a lot of people having an access to the medical things, medicines and easily accessible medicines, we see a lot of patients have intoxications which are coming to the hospital because of the various reasons. So I just wanted to ask Dr. Sunil Karan, kindly unmute.
Yeah, yeah. Sorry. Yes. Yeah.
Just I wanted to ask you regarding the what is your experience about this particularly intoxication, in particular to the yellow phosphorus. What is your experience?
Yeah, so I think being in an urban center, we don't kind of get the numbers that probably a semi-rural setup or a government setup gets, because most of these people are poor. But we see about 4, 5 in a year, and I think the onset of plasmapheresis has certainly changed the way we manage things. I think because gone are the days of all those costly sort of liver support systems, which was not even shown to have much benefits. Uh, so particularly, I think what is important to understand is that the first this Ratol has three phases in the illness. I think that is something we need to understand, because many times when they reach the referral center or a higher center, they are in a kind of a settled state because post 24 hours. But that is not the time when you would expect things to deteriorate, because phase three of the clinical history, or the clinical natural history of the illness, happens after 48 72 hours. So that is something, so I think all these patients certainly need to be monitored for at least a period of 72 hours before they are said that they are safe, because all the primary, the liver and the kidney sort of dysfunction, the AK and the ALFs happen after that period of time. So I think that's one thing we need to really keep in mind. Uh,
I
the
just wanted to ask her what is the role of the, because most of the common things, some of the people, as I told, they will not reveal the history, what intoxication
Yes.
they are taken. It's
Yeah.
very difficult to identify because of the social reasons and because of the various other reasons.
Yeah.
Some of the patient found unconscious, somebody else is bringing. And as a
Mm-hmm.
protocol, a traditional critical care teaching about the stomach wash. So
Yeah.
how safe is they for doing a stomach wash for an unknown poison? Or in particular, if we talk about this yellow phosphorus also.
Yeah, so I think it's a controversial sort of thing. So you see, as I said, the role of gastric lavage itself is questionable, and I think if they have come uh, beyond a certain window of time, definitely beyond about hour to 4 hours, there is probably no role in giving gastric lavage, because particularly if it is unknown, there's always a high risk of them having taken a corrosive or a mixture of some corrosive. So that is when you will be actually in a bigger trouble. So if it is beyond 4 hours, I think there is no role for this, especially if the toxin is unknown and you suspect something like yellow phosphorus. And as it is, if there's no much benefit, because even if there is benefit, it is about only when you use a lipid-based system, as you rightly said, a coconut oil or something. So if you are very sure it is yellow phosphorus or any other phosphide, with a rodenticide, which is a phosphide-based thing, then we could probably try. But if it is an unknown poison, I would say it is better not to use gastric lavage.
That is correct, sir. Actually, a lot of people, I think, since ages together in the medicine, you have been taught
Yeah.
whatever the patient taken, the poison is there, irrespective of the time. about doing a stomach lavage and other things. I think as the science going on and we are having more and more understanding about pathophysiology, their complications, the problems, we are becoming more and more mature about what to do stomach wash. Second thing I wanted to ask about, what is the role of activated charcoal, sir? That is also common traditional teaching
No,
is
no,
there for
not for
irrespective of the
this
patient.
poison for certain. Not for this, yeah. So see, again, activated charcoal, if you're asking toxicology in general, there may be a role for specific you know, drugs which have a degree of enterohepatic circulation. Otherwise, in general, there is probably no role for this. And those are generally tablets which are having an enterohepatic circulation. So it's not so much for the routine poisons or medications which are not considered as therapeutic.
So that just wanted to ask about, sir, like this, the unknown poison comes, what will be the approach for the treatment for the patient?
Yeah.
Be way of syndromic approach, or you can throw some light of the unknown patient coming with the poisoning.
Yeah, so I think if it's an unknown thing, airway breathing circulation will be the first line of therapy. So assess the airway, look at the breathing, and if you think there is need for taking the airway, that will be done. And circulation to peripheral lines, start resuscitation of fluid, and if there is shock. Look at the other aspects, ECG, any changes, look at the pupils and also of course a blood gas. And in the meantime, if you get the other relevant investigation, then you know the thing. So you'll have to broadly put it into one of the five syndromes that we know about, the opioids, sympathomimetics, all the five things. But see, many times if there is a combination of mixture of things, I think it is very, very hard to detect these things, especially if it is a sympathomimetic type or an anticholinergic type. You would find that more or less the presentation may be quite similar. So that may be a little tricky to identify. But if you have already protected the airway, if you have already intubated the baby, there may be still a role for gastric lavage, particularly if you're talking about suspecting ingestion of multiple polypharmacy tablets or such thing. Then probably I'm talking about through a nasogastric tube, not through the conventional gastric lavage tube. If you have protected the airway and you're pretty sure there is no corrosive, there may be some role. But otherwise, I think in general, we would just say airway breathing circulation, fluid resuscitation, ECG to see for any QTC changes to indicate whether it is any of the toxins which are having cardiotoxicity, a blood gas, metabolic acidosis, and then calculate the gaps, the serum, the osmolar gap, the saturation gap if there is anything, and this will probably give you the clue to what is the likely toxin you're dealing with.
I think very true, sir, what you told about the things. Any young patient comes because a lot of people think that if the patient having some changes, if you are not able to explain a young patient having some EC changes, cardiac arrhythmias or ABG, I think the first most differential diagnosis should be toxicity than thinking patient having MI or anything else. I
Yeah.
think that is a very important and valid point is there. A lot of people will be misguided here, saying that we'll do for tropi
Just
or
if I can
ECG.
add, Dr. Madhusudan, I think many times what is missed is to calculate the three gaps, as I said.
Yes,
Maybe three, let us say only two, because the saturation gap is probably not a very common occurrence in our part of the world. It's more in the Western world where there is consumption of one of these dye-based things. But otherwise, calculation of the osmolar gap and the anion gap gives a significant clue to what we may be dealing with.
I think the point of care test will be giving a lot of differential
Yes,
diagnosis for
yes.
you. If you're doing an ABG and calculated the delta gap, osmolar gap,
Yeah,
and the delta delta gap is there, I think we'll get a lot of idea for there. I think
true.
that will be the first clue for all people to understand. I think in
Yeah.
very the listeners is very important point is there. Any person coming with the history is not very clear. Young person is there with the other issues are there, not able to come to the conclusion. I think the point of care test of ABG will give a lot of ideas. Not only seeing about the carbon dioxide or oxygen, but the time about the calculating the gap will give differential diagnosis for you. And the other thing, I'll come back to you, sir, again. Somshekar, sir, like this, some of the people come with some bottle. Somebody carrying a person has taken this poison is there. Some empty pills are there. And as the particular topic is they're talking about the yellow phosphorus, what will be the plan of action, sir? Because I think the treatment start at the level of the emergency room itself, not patient coming to the ICU, as time
Yeah.
is very important. So that somebody has called from the emergency room somebody has called from the emergency room saying that the sir patient came with a yellow phosphorus poisoning, and the initially patient will be 6 to 8 hours or 12 hours person will be rock stable, nothing issues are there, and they have the
Exactly.
controversy whether to admit the patient or not. Other things are there. What is your suggestion at that time, sir?
If you are sure, if you are 100% sure it is rat poisoning, definitely we need to admit them, sir. If you know it is yellow phosphorus. So actually speaking, if we are not talking about today, at least 15 years ago, if I see a rat poisoning case, it was 100% mortality. So you can't let a patient who has taken yellow phosphorus to go out of the hospital if you know that he has taken it. And obviously timing of ingestion definitely plays a very, very important role. Most of the time, we see them with signs of acute liver failure within 72 hours. At least by the start of 72 hours, you will definitely see rising INR, worsening lactates. So you know that the patient is in acute liver failure if the patient presents at that time. But if they present early, definitely you have to keep them in your hospital, if necessary in ICU, to monitor them for the next 72 hours from the time of ingestion. So that is mandatory, sir. And we need to do ABG at least once in 12 hours, even if the patient is stable. And your ABG and the PTINR definitely gives a hint when the patient is worsening. Along with your LFTs, your PTINR and lactates in ABG will give a hint that this patient is going into acute liver failure. So previously, I mean, when the plasmapheresis was not this active, at least 5-6 years ago also, we have done transplantation immediately whenever if the liver was available. But today we are just waiting and looking for a time to start plasma exchange as early as possible. So once you see the INR more than 5, I don't think we should wait at all. We will just start them on plasma exchange.
I think we meant very valid point, sir. Actually, whenever the patient come to emergency room, particularly young people, and without having any signs and symptoms very specific, or most of the investigations are normal, it's quite difficult for the family to patient to convince get admitted. As Dr. Sunil Garu told about the patient requiring and monitoring. I think I'll go to one step ahead, saying that like this patient with a high degree of suspicion is there, better to admit in the monitored area, whether it is ICU or some of the monitor area is very important to identify what the problems are happening for the patient. Sometimes our assumption is there the patient admitted in the ward, and sometimes code blue happens. I think we miss the important window of opportunity, and the attention will be not there for the patient, and what regular monitoring has to be done. I just wanted to ask further questions, sir. Suppose the patient came to the ER. We done the basic investigations for the patients are normal are there. And as you told about the some investigation specifically, what I understood about the LFTs, the coagulation parameters, I think I'll add one or two more, monitoring the glucose, because important function about the liver, about synthesis, metabolism, and
Hypoglycemia.
detoxification.
Lactates
These
as well.
three,
Yeah.
I think, functions are very important to monitor. So that I think just like a OP poisoning, we are making a chart to monitor every second hourly, fourth hourly. I think what is your suggestion, sir? How many frequently we should do this investigations and do monitoring in the monitored area, particularly for the lactates, the liver enzymes, the what you call the coagulation parameters, and the mental status changes for the patient.
See, based on the initial investigations, basically, if the initial investigations are normal, I would like to repeat them once in 12 hours. Actually, if the initial investigations are suspicious, already we are seeing elevated enzymes and mildly elevated INR, maybe we should be repeating once in 6 hours. It is only for the timing. See, I don't want any multi-organ failure or any other organs to be damaged. So before I initiate a plasma exchange, if the treatment is early, I know if it is 100% sure this is yellow phosphorus poisoning, I would like to start the specific treatment which is going to help the patient as early as possible. Here, plasma exchange in yellow phosphorus, we are actually removing some amount of the toxin also when we are doing the plasma exchange. So we are trying to decrease the pathology or whatever inciting agent when we are doing plasma exchange along with taking care of your liver failure also. So as early as possible, if I can start a plasma exchange, that means when the signs of acute liver failure sets in, I will start a plasma exchange. To know that, I would like to know the PTINR and lactates at least once in 12 hours. So, if we start plasma exchange early, we may achieve more clearance of the metabolites, the toxin, all those things, and all your inflammatory substances also early. This can improve the survival if we start plasma exchange early in these patients.
Before going to the details of a plasma exchange, I just wanted to ask Sunil sir. So regarding the plasma exchange, there are both the techniques are there, filter based, and the other techniques are there. Suppose this patient came to your ICU, we decided that I think we came to the conclusion that patient having and the problems are there about the coagulation and transaminitis and the lactates are increasing, so that we are planned for the plasma exchange. So that which method we'll choose and why we'll choose, sir?
Yeah. So I think both methods are equally efficacious, but the filter method is probably needs a HD catheter, whereas the centripetal method, which generally can be done with a good central venous catheter as well. In fact, they even say they can use the membrane-based system can even use a very good gauge peripheral line, but I think give and take a good central access is useful, except for the fact that if the blood pressure is a bit up and down, then you may not get as much with the centripetal or with the membrane based technique. But one thing about all this is that we are not you can prolong the time of each session by an hour or so that time you can run it on a lower blood speed. But since we are also talking about low volume in most situations or at the most normal volume, as Dr. Somsekhar already mentioned, that the data I think one of you did mention about the CMC paper. I think we have moved more towards one or less than one exchanges, which when I talk about the volume exchange. So I think the membranous one is as effective as the other one.
And what about their complications and the other issues, sir?
Yeah,
Regarding
so
the
I think the
requirement of
usual
sugar and blood products?
so the usual complications are of any plasma exchange, loss of calcium, of course, you would also talk about depletion of coagulation, but in this situation, we are already having a coagulation kind of an abnormality existing. And so let us put it for exam purposes. Whenever we talk about complication, I think it's important to classify it as procedure related, where you are placing the catheter. So that is one set of complications, and of course, complications related to the plasmapheresis itself. Hemodynamic instability is one problem, which again is less often seen these days with the low volume exchanges. And of course, electrolyte abnormalities, primarily calcium, is what we would be worried in this setting. Now, I'm specifically holding on to this setting because if you're talking about plasmapheresis in other system, then of course coagulation, increased risk of sepsis, all these things we discuss about. But I think in this setting, since it's more likely to be a low volume, I think it's largely going to be hemodynamic, plus of course some electrolyte abnormalities, which we'll be more worried about in this scenario.
So that you are thinking that both membrane-based and the filter-based techniques are both are same, not having much superiority of one than another, sir.
Yeah, this is the ease of doing. Membranous probably is a little better off in terms of doing that way. But otherwise, I think if you look at data, it is not very different, both of them. Yeah.
I'll come back to Somsekhar, sir. Before that, I think Sai wanted to know any role of the serum phosphorus monitoring as an indicator for hepatic regeneration with ATP synthesis. Along with the other investigations are there, a lot of people ask the
Too
question.
early, I think in the acute phase, it may not have a role.
Yes.
Dr. Somsekhar, you can correct me.
Agreed, sir. I agree with you. See, when
In
we
fact,
are
that is used as a marker of prognosis in the acute, the first 1 week actually. Yeah.
after once we do, therapy, yes, after doing adequate therapies, once we think the INR is coming down,
Yeah.
immediately after plasma exchange, you may see that everything is settling down. But to know the actual prognosis or whether this patient needs a further therapy or is she improving, definitely it plays a role. We will definitely try and do that to prognosticate the patient and see how many sessions of plasma exchange are required. So regeneration, obviously, as you said, we will know the regeneration of hepatocyte. We definitely try to do.
Okay, sir, Somashekar sir, actually the thing is that as I told about this patient, when she came initially about with INR of 8,
Yeah,
the patient lactates were going sky high, more than 10, 12 lactates are there. So
yeah.
that how we'll plan about the plasma exchange? I think the CMC paper is showing very well about doing an low volume plasma exchange
Volume,
to the
sir.
patient.
See, what I strongly feel, sir, it is individual based. See, when we assess the patient, if we think this is patient is volume depleted, and there is no need of low volume or anything. If you think the patient requires some volume or is volume depleted, you can go for any type. And I would prefer a high volume plasma exchange, because if you do a high volume plasma exchange and if the patient is able to tolerate, the number of sessions may come down in these patients. So it depends on if the patient is already volume overload. If you have a suspicion of pulmonary edema and all, then definitely you go with low volume plasma exchange. That is for sure. So most probably this study, I strongly feel it is cost cutting which has done. So high volume plasma exchange is definitely useful whenever it is possible, if with no contraindications. So if we can do a high volume plasma exchange, definitely the number of sessions will be little less. But in these patients with acute on chronic liver, I'm not talking about this patient here, any other acute on chronic liver failure, those patients we may not be able to give them a lot of volume. But these are ideal patients who can undergo high volume plasma exchange without any contraindication. So, see, this study is done most probably because most of them are done in CMC. So, but even this says even low volume plasma exchange helps. But ideally, if you have a situation, please go with high volume plasma exchange, at least the first one. If the patient is tolerating very well, we can as well continue either daily or alternate day. But high volume plasma exchange is preferred modality in acute liver failure.
So that as a part of Somashekar sir, as a part of the counseling, the people ask about how many plasma exchanges has to be done before coming to the conclusion, saying that patient showing signs of improvement. If the patient not showing signs of improvement, then you have to go for some alternative treatment.
Next. Ideally, sir, any patient with acute liver failure, even in this patient, that from day one, we should be counseling them about the need for liver transplantation, because we are dealing with acute liver failure. Whatever may be the reason, etiology can be anything, but we should start counseling them about the liver transplant. And simultaneously, when we are doing a plasma exchange, we should be, if there are any donors available in the family, we should start counseling them and screening them for a potential as a potential donor. So definitely we have to I mean we it is only 50% that these patients can come out with plasma exchange, not 100%. So we need more and more studies to say this is going to be better treatment, or this is going to be the treatment other than liver transplant. As of today, we should be on a 50-50 basis initially. Yeah, if all the patients improve, if more number of case studies come out, and if we can have a series of patients with rodenticide poisoning who are improving with plasma exchange, that is now, as of now, definitely all these patients should be listed for urgent liver transplantation and then start on plasma exchange. If the patient improves, definitely it is good. If the patient is not improving or not showing any signs of improvement after the third plasma exchange, I would say we should stop there and go ahead with plasma exchange, I mean, with the liver transplant.
Thank you, sir. Sunil sir, just wanted to ask about, see, everywhere the plasma exchanges are not available for buying the time to understand or referring the center, say, patient to the some other center where they can do PLEX. Because for the PLEX, it requires multiple blood and blood products. That each and every center is not possible. So in the meantime, any supportive role of any NAC is there, sir?
Yeah.
Is for yellow phosphorus intoxication?
Yes, yes. So I think as with any transaminitis or hepatitis, NAC has a role. I mean, if you look at studies, there are some studies, most of it retrospective sort of studies, which have shown, some have shown benefit, some have shown no benefit, but there's no harm anyway. And from a physiological rational perspective, the fact that it regenerates the so what you call the oxygen radicals and other things, it makes sense using NAC. So I think NAC is not a, it's a useful thing to use, or no harm in using it. So definitely there is a role. But I think more than NAC, coming to the question that you mentioned, I think it is important to understand that these patients need to be referred early to the center. Now, many times what happens, you find that everything is being tried in the other places before they get sent. And by the time they reach the higher center, they're already very, very sick. I think that is what we don't want, because even if we say plasmapheresis, again, when do we start, how much is very individualized, as Dr. Somsekhar mentioned, because even today, I don't think we have very clear guideline, but give and take, I think on the whole, we would say INR of more than 4 or 5, not resolving, not getting better. We would, and rising by day 2, day 3, if there is a rising trend of enzymes, I think we do go ahead with plasmapheresis. Dr. Somsekhar, you correct me if I'm wrong.
Yeah,
Uh,
I agree with you.
yeah, because there is no clear. It's not like King's College criteria or some criteria where we say, okay, this is the cutoff to do INR or something. But give and take, based on the clinical need and such other things, we do that. But what is important, I think, is to refer the patient early, because by the time the patient comes to, if he's already on all sorts of problems, then because see, many times these people need early assessment of volume. Those are the things that I think which can be taken care in the smaller centers. Lactate, but initial part, for example, the lactate is not because of liver dysfunction, but it is more probably hypovolemia induced, etc. So I think important thing is to get good volume resuscitation, not to the point of causing lung injury, but using whatever method, echocardiography, pokers, anything, because most of these people are behind in volume. So many times just the volume resuscitation itself will sort of resuscitate them well enough. And I think this is probably one area where this tempering of volume may not be something we would be looking for. We'd probably be a little more judicious with volume replacement. I'm sure most hepatologists would agree with us that they are more keen to give volume here than we would have thought of in maybe some other circumstances. So good volume resuscitation, monitoring, and NAC, of course, and avoid any other liver toxic agents. And I think at the right time, refer them early. I would even say, kind of get a good resuscitation, and then get them to the higher center where you can do both PLEX and transplant. That's probably the best way of doing it, because as you can see in the Tamil Nadu experience also, the mortality by just having a well organized system of the hub and spoke has actually gone a long way in improving mortality. Leave the transplant apart, but I think generally, and if you look at the data for plasmapheresis, there's not enough data to say it has reduced transplant, but it has definitely increased transplant free days. So in that way, I think it is, there are reasonably good objective endpoints for us to use plasmapheresis, and that's something we probably have to aim for.
Just wanted to ask Sunil sir, as a protocol in your hospital, what is the timeline is there once the patient having this yellow phosphorus intoxication for the plasma exchange or PLEX, or on the basis of investigations we do any time?
Yeah, I think it's more basis of investigation and concurrence with the hepatology team. So give and take, generally we would say 4.5 of INR or nearing 5. 4 to 5 is the time when we really think about it, along with raising enzymes and bilirubin climbing up. So definitely by day 3, if we are reaching one of these or two of these targets, then we start thinking, because what we need to see is whether the liver function is continuing to worsen, number one. Number two, have you entered that phase 3 of the illness where you know that there is definite significant liver impact, or almost what we would consider as heading towards liver failure. And I think that's the indication where we would probably think. And at the same time, as Dr. Somsekhar mentioned, start working for listing the patient, because that takes time. The paperwork, getting the right donor if you have. Maybe before you put him on a super urgent list, you will probably be looking for a donor in the family. So these are things you have to start thinking by day 3 of phase 3, which is day 4, day 5 of the consumption, I would say, because day 1 is generally vague symptoms. Day 2, day 3, generally not much happens. It is after 72 hours you find that they start slipping into this liver injury phase.
The other things are, one of the attendee wanted to know, they had some Referral poisoning case with arrhythmias. Patient had refractory arrhythmia. They had done in spite of doing early PLEX also. So that what is your advice for this type of patients? They started early PLEX within the time duration what patient came but in spite of that patient having an arrhythmias are
Yeah.
there.
So
What is the next
see,
level of action?
phosphorus, as you know, phosgene is the toxic agent. It's an intracellular toxin. So most presentations are liver, ALI, and ALF and AKI, but about 10 to 15%, or even nearing 20%, I think, do have myocardial involvement. So yeah, plasmapheresis is there as a role for for maybe this thing to clean up, or you would consider to reduce the toxin levels. But at the same time, I think this is probably an indication where you would consider ECMO as an option if you find that the arrhythmia is very resistant, because sometimes with the tachyarrhythmia also comes significant cardiomyopathies, or where you find that there is significant cardiogenic shock because of even poor inotropy as well. So it's a vicious cycle. Basically, the tachyarrhythmia itself will cause the LV function to deteriorate, or the other way around. But and once they enter this phase, it needs at least a week for you to actually get that intracellular toxin out of the system, out of the cell. So that's why I think these are again indication where VA ECMO will be a useful tool to have.
I think is one of the other indication other than the
Yes.
primary cardiac reason for the patient putting on VA ECMO in cases of intoxication also.
Yeah.
Will be tied over the crisis, and we are giving another support in the form of
It
antiarrhythmic
almost
medications
behaves
are
like
given.
your aluminum phosphide in those circumstances.
Yes, that's what I think a lot of cases from the Madhya Pradesh, they have the thing when they're
Yes.
using a lot of the extracorporeal support for the patient.
Mm.
The other thing is this about I just wanted to about ask to Dr. Somsekhar Garu. The actually whether the plex working or not. I think before the plex we have some monitoring, and the after the plex we have some monitoring. It's specific to the ferritin and von Willebrand factor. Any role is there of these factors to monitor whether the plex is working efficiently or not? Because lot of discussion happening about low volume, high volume, with the timing, the precautions, blood and blood products. Whether whatever the therapy you are working, sometimes we thinking that as you told about high volume, because of hemodynamic instability on the support, we cannot do it. Whether this will be helpful, the monitoring of the von Willebrand factor or ferritin, saying that your plex is efficient, the timing, duration, volume, and whether we can do monitor before the plex and after the plex, any role of monitoring these factors?
Ideally, sir, yes. Ideally, definitely, when we monitor before and after PLEX, we will know whether the patient is responding. But unfortunate thing here is these reports immediately post PLEX, everything would be normal, like our INR.
I know.
And again, after a gap of 24 hours, they may worsen. So definitely, serial monitoring definitely helps. So the level, if it is improving, then we can say the liver is regenerating. But it may not happen immediately after first session or second session of PLEX. But definitely, serial monitoring is definitely going to help us know whether the liver is regenerating, along with your regular liver function test and INR. So I would suggest we should be doing these things.
I think initially, as we discussed about monitoring about the lactates, glucose, encephalopathy, and the coagulopathy.
Yeah,
Along with that, we know about the progression of the liver, what is happening,
yeah,
and whether plex working or not. Because this is a $1 million question that if the plex working and which is the transition point is there, when to, as we told each and every person to involve for liver transplant, but
yeah,
to identify whether your treatment working or not. I think
yes.
this is an additional component is there along with the routine parameters what we are seeing. This will give you a fair idea about you, what are the other things are working.
Yeah.
Sunil sir, I think any role of, because a lot of people discuss about a lot of other medications are there, and a lot of people have the interest about the lipids, the role of intralipid or trimetazidine in cases of this yellow phosphorus poisoning.
Yeah. See, it's all very anecdotal. Very honestly, I think now with plasmapheresis, I would not be keen to try all these things. Maybe for gastric decontamination, as we had spoken, yes, but not so much for these things. But Dr. Somsekhar can add throw more light. I think with the plasmapheresis, all these, which I think that's the only thing which we have reasonably good low grade evidence or moderate grade evidence, I would say. And even then you can argue there's no good RCT, there is no good this, that, and the other, but at least there is lots of good amount of subject collection or population, if you pool all the studies to say that there is indication that it works. So why waste time giving things which are sort of irrelevant? I mean, maybe in certain other situations like your lignocaine toxicity or such other places where we still don't have anything else, you can probably look at all these other modalities. But I think in this situation, my personal bias would be not to use them. But of course, I would leave the question open.
No, I think you are 100% correct, sir. Before, when the antidotes are not available, a specific therapy not available,
Correct.
people do light or permutation combinations, and everybody is having their own experience and try to say that this thing is working. We
Yeah.
don't know what exactly working. It's because of the natural reason the patient is improving. The amount of he has taken is very less, or he has not taken, he had vomiting. Multiple reasons are there. I think, but the present situation, we are having a lot of support and evidence is there for the plasma exchange. I
Yes.
think the other things what we are discussing, where the for just buying the time. But as you told, very important for the any like any AMI or stroke, we have the window period. In the same way, time is very important in cases of intoxications also.
Yeah.
And the centers which are capable of managing all these things, as you told, very clear statement. The centers which are having management of both PLEX and liver transplant, both should be available. I think then all these things are not important or not having much of clinical evidence. And in fact, they'll be causing some complications and problems, chemical pneumonitis, aspirations, and other things are there. I think, sir, we told enough about the liver transplants. What are the criteria we follow, sir? Actually, the CMC builder they told about the Kochi criteria, and the traditional teaching is about King's College criteria. What we follow in cases of this intoxication?
We generally follow the MELD sodium score and the King's College criteria only, sir. So all these things, simple clinically, INR and your lactate, both these things will clinically will let us know your investigation wise, and hepatic encephalopathy. It's very simple to assess whether someone is having acute liver failure. So MELD sodium definitely helps, and King's College criteria is what we generally look at.
Yeah. There is some emerging data for Alfred also, right, Dr.
Yes,
Somesh?
yes, yes,
Some
yes.
data, especially in the Indian scenario, they say it may be better, but I think not enough people, it's not tested enough, so probably.
Exactly, sir. Yeah.
Okay. The other thing is there's about, I think some question is there. The role of PLEX in cases of infective acute liver failure. Just the out of interest because the listeners wanted to know about this one role of PLEX. We are discussing, I know about the particular talk about yellow phosphorus, but any role of infective ALF about the PLEX is the same. Supporting evidence is there. What we are talking about the yellow phosphorus.
So when we are talking about viral hepatitis, infective acute liver failure is most of the time acute viral hepatitis,
Or maybe tropical fevers also.
tropical fevers. So I want to differentiate these two and talk about it. So when we are talking about tropical fever induced acute liver failure, I don't think there is a perfect role for PLEX. But when we are talking about viral hepatitis related acute liver failure, definitely by acute viral hepatitis like A, E, and B, this definitely helps as a bridge. The immune complexes, it is the immune mediated destruction of the liver which happens in viral related acute liver failure. So PLEX has a definite role when you are thinking of acute liver failure in these patients. And it is definitely sometimes it reverses the acute liver failure, or it definitely acts as a bridge for liver transplantation. So there is definite role for PLEX in viral induced acute liver failure, acute viral hepatitis related acute liver failure. But tropical infections related acute liver failure, it is not just acute liver failure. You definitely have other coagulation problems. And I would say we will not treat that with PLEX. Other than that, we have multiple other things now in our hand. I think maybe that would be better than PLEX here in tropical infections.
I think short of it, ALF and ACLF are two
Yes, sir.
cases where plasmapheresis has a role, but definitely, as Dr. Somshekar mentioned, not for tropical kind of thing. Yeah.
I think that is very clear because what happens in cases of particularly for the tropical fever, just for the completion sake, will not divert our discussion to there. When the patient comes with a dengue with warning signs and coagulopathy, multiple complications are there. I think when we push to the wall, we don't have any other options are there. A lot of people tried this one, but with the variable outcomes and results. I think this is not the topic for discussion today, but which out of interest put so that we understood. I think one of the question is there in the this one, sir. They wanted to know about the phases of the rotal intoxication, rotal poisoning. What are the different stages are there?
Yeah. So there are roughly, arbitrarily we would say 3 stages. First 24, 48 hours is more of GI kind of symptoms, vomiting and this kind of, and tummy pain, abdominal pain, lots of appetite, etc. Then there's a quiescent stage, but 24, 36 hours to 48, 72 hours. That's the time when most of the time they come to your center, like a higher center, and they say things are okay. Why should I get admitted? As Dr. Somsekhar mentioned, there's always a fight. Why should I get admitted? This, that. But I think that's the most important time when we need to be very watchful and say, no, there are. You may or may not have subtle changes which happen in the liver function, but after 72 hours is when you find that things start going. That's the phase 3 when you start having ALF or even AKI sometimes. So that's roughly you would divide the 3 stages of yellow phosphorus in particular.
I think it's quite important, as you
Yeah,
told about,
yeah.
because the time duration what the patient is coming is important
Yes.
to understand.
So,
As you told about,
just if I may deviate a bit, I think the other rodenticides, even the aluminum phosphide or the zinc phosphide, also have this window of 72-hour kind of a thing. So, I think broadly for these rodenticides, it's very important to know that this don't discharge the patient home like how we would not do for an OP poisoning. So 3 days is the minimum time you need to monitor these people.
is absolutely correct, sir. I think the important this phases is important. Whether the patient coming for presentation, which day is presented to your hospital. Sometimes, as Somsekhar sir told, patient being presented after 2 days or 3 days is there. At which stage we'll able to identify and understand also. On that basis, we can do prognostication also.
Yeah.
Even after 72 hours, where most of the investigations are normal, LFTs and coagulation parameters and patient conscious oriented. I think the patient not having much of issues and problems are there. I think this phases is quite important for all of people to understand.
No, sir.
Yeah.
These people should be monitored closely for 7 days
Yes.
after the ingestion of poison, sir. Even though if they are asymptomatic after 72 hours, they should be closely monitored for up to 7 days.
Correct.
To say that they are out of the
Danger.
they
Yes.
out of danger or out of the quite safety zone is there.
Yes.
The other important thing, I think, the initial part of discussion, lot of discussion was there initially about regarding the Mars and other things are there. In present day, in the era of the PLEX and the what we are doing about liver transplant, you think, sir, any role is there?
No, sir. There is
No,
no role at this
absolutely
point
not.
of time. Better avoid those things.
Yeah.
They are not helpful.
Thank you.
In fact, I think Mars has completely fallen into disrepute. Maybe there is some center which, well, not in India probably, which use Prometheus, but because it's a little more cheaper since you're recirculating the albumin. But I think give and take, there is no role for these things. And I think the onset of plasmapheresis has uh, given you that bridge that you're looking for either cure or transplant.
Venkat, over to you, Venkat.
Yeah, thank you. Thank you both, Sunil sir and Somsekhar sir, on bringing that. I just wanted Dr. Somsekhar to explain. I think in the last 3 years with the Association of Gastroenterology team, we had a very broader spectrum, maybe widened spectrum of indication for this plasma exchange. We spoke about some viral hepatitis, spoke about some acute and chronic liver failures. We also had a situation where some of those Wilsons, where there is an acute and chronic decompensation. In the last week, we had a younger child, who had an acute decompensation, coagulopathic, encephalopathic, young boy. We tried to bridge because the family was initially not convinced enough for a mother donor, live donor liver transplant. So Dr. Somsekhar had a discussion with team, and we could actually start a PLEX. The moment we did PLEX, the boy improved. We could extubate, and in quick time he rebounded. We did a second PLEX. He again responded. The same team repeated. The PLEX helps them, but it's just a bridging therapy.
Yeah.
So finally, Som and the team spoke to transplant team, convince the family, see, this is all just a temporary bridging, but he finally needs some kind of rescue therapy. So Dr. Som, you can explain. So the session was more towards a probably yellow phosphorus, but the expansion of the widening of the
Indications.
PLEX has been widened. We ourselves has been a lot of spectrum. I think after you...
We have some series of acute liver failure secondary to acute viral hepatitis, sir, where PLEX has improved and we avoided transplantations. So at least in the last 2 years, at least 5 patients of acute liver failure, otherwise who were thought to be definitely required transplantation, we did 3 to 5 sessions of PLEX and the ALF reversed. So these are some new learnings all of us are learning actually.
Can you enumerate them, sir?
So we had acute viral hepatitis A, acute viral hepatitis E, 2 of acute hepatitis A and 2 of acute viral hepatitis E, where they had acute liver failure. They fit into King's College criteria for liver transplantation. We talked to them about liver transplantation and we thought we will bridge them with PLEX. But to our surprise, they reversed completely. And there was one drug-induced liver injury where there was acute liver failure. This person was himself a pharma guy. I mean, he was working as a representative to a pharma company. I forgot the drug. I think it was
we have seen some anti-tubercular drugs. We have
anti-tubercular drug, yes, but this guy specifically
anti-epileptic, valproate.
Yeah, anti-epileptic. He's been taking anti-epileptic. I think it's sodium valproate, and he had acute liver failure. We were worried, but all these 5 patients were they were into the King's College criteria for liver transplant. We initiated PLEX only as a bridge therapy, but still most of them, I mean 5 of them at least, we could bring them back without a liver transplant. That means transplant, it is not just a bridge, it can be a therapy today in many cases of acute liver failure if you select them properly.
Okay.
So, and maybe we can start this as a bridging for liver transplant also, because liver transplant, it's not as easy as we talk. A lot of problems, donor problems. We don't get a liver at time. Even the family members, if they're willing, they won't. I mean, suitable liver may not be available. So all these patients with the acute liver failure, when we know there is a specific indication, I think we should be trying plasma exchange, is what I feel today.
Yeah.
So if I may add, Dr. Somsekhar, sorry.
Sunil sir, please.
Yeah. So I think even in the post-transplant setting, if the liver is kind of struggling to take up, it, people have used it as a bridge as well.
Exactly.
Right?
Exactly. Yes, sir.
So that's the add-on thing. Any other things you saw, sir, in this recent times of as a PLEX expansion, use of PLEX and acute liver? So overall, what we have been seeing is most of these patients, if they are been not had that major liver injury, probably supportive care, maybe NAC takes off them. We see some of them going into further sicker state, going of INR, worsening liver functions, going into encephalopathy, getting into a need of PLEX, bridging to a liver, some of the liver transplant. Some of them actually recover from the PLEX to a recovery. And the last one, those who actually, even though they have a partial recovery or a temporary recovery, they kept on worsening, needing a bridging to a transplant. If that doesn't happen, probably they don't make it. I think now at this point of time, the gold standard remain to be, if the PLEX not working, it's a bridging to a transplant, and the last resource will be in that. So this is the spectrum we have been seeing. And just I wanted Dr. Somsekhar to comment, is that kid alive and coming back to you, or how is the...
Yeah, he's good. He's good. He's absolutely good.
So
maybe
that
I'll
was
be
actually
seeing
very
him next week.
gratifying thing. So the family was very reluctant initially for the liver transplant because of many reasons related to the surgical.
So this was acute Wilson's. Wilson's. He had acute liver failure. 8-year-old boy. Yeah,
8-year-old boy was very agitated, aggressive, shouting, screaming. In early part of encephalopathy, got drowsy, shifted to ICU from the initial admission to the ward side at a pediatric unit, then been undergone a PLEX with a pediatric cath, and then he improved. Then he deteriorated. Then again, second cycle he improved. He kept on having that on and off with PLEX. So finally, he got a mother's donor liver, sir.
Yeah, mother donated.
So it was a gratifying story last week of us. So I think we had a good discussion. So overall, why we brought this case is Ratol and yellow phosphorus is not uncommon in this part of the world. As Sunil sir said, maybe it's not an urban toxin, but cases get referred from the peripheral satellite centers to higher centers like that. And we do see 1 or 2 cases in a month, if not very frequently, in one of our unit. And we have seen liver being predominant injury, as everybody pointed out. And this kind of therapies, as we all discussed, keeping an eye on all the parameters, as said, glucose levels, lactates, encephalopathy, coagulopathy, enzymes, and keeping them track and probably offering them PLEX in a time, bridging them to the transplant when it is not responding. This kind of information and very well made points. Sunil sir talked about cardiac possible toxicities, AKIs, other things which has been not uncommon. And probably we'll bring one more day about other rodenticides. I think Dr. Sai trying to point out both aluminum phosphide, zinc phosphide. So is there a equally common, Sunil sir, or you are not?
Yeah, aluminium we see quite a bit in this part, I think, but of course it's probably more than the northern states, but we do see one odd coming through here. But superwarfarins are not, anticoagulations are becoming more common these days. It used to be very common in the West. In Australia, we used to get every 1 month one. But superwarfarins are now becoming more common here because they are the commercial ones, which is the non Ratol, which is Ratols and all are more sold in the smaller, shops, which is the unorganized sector. But the organized sector have the superwarfarins. So I think they are becoming more common these days. We get at least one in a year because that's where the urban city crowd, as you said, they pick it up from the bigger shops and get it on. So of course, nothing much to be done. Vitamin K prolonged therapy, but there is a risk of bleeding in these people. I think that's what. Yeah.
Okay. Sai, any comments from you among the aluminum phosphide or zinc phosphide? What is your experience during your AIMS days?
It is one of the commonest phosphate poisoning in Madhya Pradesh. When I used to work in as a DM in AIMS Bhopal, almost every month we used to get 2 to 3 cases of aluminum phosphate poisoning, along with zinc phosphate, sir. And in the aluminum phosphate poisoning, within 12 hours, the patient should mostly will land up in severe LV dysfunction.
Yes.
So we used to save. We tried saving 2 patients with the VA ECMO in those kind of situations, sir. At that time, as when a VA was not feasible or not available, we used to try all these kind of intralipids or trimetazidine, etc. But we found that VA is relatively efficient and we could save few patients with aluminum phosphate poisons.
And what is the duration generally? It's been 4 to 5 days.
So most of the patients, generally the aluminum phosphate is available as a tablet form, sir. So generally they used to present within 6 to 8 hours and they used to land up in severe dysfunction within 24 hours. So the worsening would be very rapid. Those kind of
so usually they would need a week of VA ECMO. So we had last month a guy who, because that's the time needed for the phosgene to be eliminated from the intracellular system and regeneration of the ribosomes. I think that is where it hits. So that is the theory, at least. That's what they say, that it needs a week. So 7 to 8, 9 days is the time, unless they spiral in. So I think important, as Dr. Saiteja said, is to catch them before they spiral into this multi-organ failure as a part of the cardiogenic shock.
Yes.
So many times when we go in, it will be EF around 30%, 25%, not down to 10, 5%, then you are finished actually, because by the time they reach that thing, it is extremely late. And even getting a catheter in these people is a nightmare. So one of our patients last year who came that sick, they couldn't even start a peripheral VA. They took him to OT, started him on central VA, but he was almost like 24 hours plus on cardiogenic shock. So he just went spiraling to multi-organ failure. So I think getting them early and starting them early, because there's always a reluctancy to go down the pathway of a VA ECMO because there's thinking it's a big deal, it's a huge deal. But I think the faster we go in, better. And that I think now we know for all ECMOs, the earlier we go in, better is the chance of them coming out.
Similar kind of experience said by all the colleagues from the central part of India and even Dr. Vivek and other guys in and around Bhopal.
Ludhiana, no, you're saying, Vivek?
Ludhiana, Dr. Vivek. He says going on ECMO early and weaning the ECMO early once the
Yes, yes.
patient's toxicity. That's the way they are.
See, ours is not that much experience. I would say maybe we get one in a year of this type, one or two in a year. But I mean, ECMOs we do more, but for this indication. But what we have noted in the last 2, 3 is that I think when we have gone in at early, the heart function also preserves itself, because otherwise you're flogging the heart. In fact, the last two didn't even need LA venting because it had some reasonable EF persisting 20%. So it was enough to and offload the LV as well, because if they end up with that very low ejection fraction, then you start doing other things, venting, this, that, so many other additional things come into the foray as well.
I think we had a learning discussion. I think it's a spectrum of things which we were learning. Thank you both Sunil sir and Dr. Somsekhar, you spending our time with us. And thank you, Dr. Sai, in bringing that case, and Madhusudan in moderating the session. Thanking all the participants. We end the session. I think we will bring many more sessions like this in upcoming sessions. Thank you all. I conclude the session. Thank you, sir.
Thank you.
Thank you, Somsekhar. Thank you, sir.
Thank you. Thank you, sir.
Thank you all. Thank you very much for the opportunity. Thanks, Venkat. Bye.